My name is Dr. Ehsan Bhatt. I'm an orthopedic surgeon specializing in trauma and orthoplasty as well as sports injuries. I'm a lecturer in RCSI Bahrain. Today we are going to do an examination of orthopedic joints in a way that it will be easy for the students to go in the exams and do it smoothly. Today we are going to do an examination of the knee joint. Just to give you a brief about the knee examination, so any joint in the body that you examine, this will be the plan: look, feel, move, and special test. Hello sir, my name is Dr. Ehsan. I'm going to examine your knee today. It will involve touching your knee. It may hurt a little bit. If it hurts you, just let me know. Okay sir? What's your name?
Ibrahim.
Ibrahim. Mr. Ibrahim, do you have pain in the knee anywhere?
No.
Okay. So the first thing I will do is look. So in the knee, and number one thing is to have a proper exposure. So you should be able to see the quadricep muscles and the full legs. So preferably the patient should be in shorts and t-shirts. You should be able to see leg from front, side and back. And you comment on what you're looking at. Okay, for inspection of the knee, again the exposure is important. You get the patient to stand in open space. You look at the knees from the front. You look at the quads. You look at any swellings, any deformities. The deformities that you can see from the front include varus or valgus deformity of the knee, which are the bow legs or knock knees in layman term. And then you also see any scars or any muscle wastings. Turn on the side, sir. Turn around. That's it. So from the side of the patient, you're looking for any fixed flexion of the knee or recurvatum. Again, you're seeing any signs of swelling, deformity or scars. Turn around, sir. Turn the back. Okay. Now you look at the back of the knee. Here you're looking at the popliteal fossa, any varicose veins, any swellings, any previous scars and any deformities. Turn around again, sir. So we see the other side. And here again you're seeing the other side to see if he has any recurvatum or fixed flexion deformity. Thank you. Now can you walk, sir? So here we are getting the patient to walk, and you look at the gait and you assess if he has any abnormality or any instability of the knees while walking. So we've completed the look part of the examination. As well as the gait part of the examination is done. Now we're going to go to the feel part of the examination. So when you're feeling the knee, you want to have a process in which you go smoothly from one part to another part of the knee. So feeling the patella, and while you're doing it, you should look at the face of the patient to see if he has any pain. Both sides, feeling the patella, moving it from right to left to check if he has any pain anywhere. Any pain, sir? No. Then you feel the quads tendon at the top, feel the patellar tendon at the bottom. Any pain, sir? No. Then you bend the knee, because to feel the joint line, you have to bend the knee. Now I'm feeling the medial joint line, which is here, and the lateral joint line, which is on this side. And during that, I'm also looking at the face of the patient to see if he has any pain in the joint. Patellar tendon, tibial tuberosity, proximal tibia, distal femur, and the popliteal fossa. So that's the right knee done. Now I'll go to the left side. Same thing, joint line, medial, lateral, joint line. Any pain, sir? Anywhere? Okay. Patellar tendon, tibial tuberosity, proximal tibia, distal femur, quadriceps tendon, and the popliteal fossa. Any pain anywhere in the knee, sir? Okay. We're also touching the temperature of the knee from the top to bottom to see if anything good, and we are comparing the two sides. Temperature of both knees is normal. That's the feel part of the knee is done. So next we go on to the move. Movement of the knee is flexion extension. Can you please bend the knee, sir? Fully, as much as you can. So that's the full flexion of the knee. I'll just push it to see if there's any further flexion of the knee. That is full flexion, about 160, 170 degrees. Then I extend it, and to check passively, I'll just bring it up and see if it is fully extending. Same thing with the left side, full flexion, active, and then passive. Flexion is full. He is not in any kind of discomfort. Straightening the knee up, it's full extension, and then I further extend it to see if everything is good. So full range of motion of the knee. Now we come on to the special test. So the test for effusion is called as the patellar tap test, and in this, in patient with the inflammation of the knee, they will have fluid inside the capsule. You bring all the fluid from the top down in the knee, and then with the thumb you tap the patella and you look at the face of the patient. You do it on both sides, bringing the fluid down and then tapping the patella, and you should feel the patella hitting the femur in case there is effusion in the knee. In patients who have a minimal amount of effusion in the knee, you can do the swipe test, in which you look at the medial gutter on the medial side of the patella. There should be a small dimple here. If this is filled up, it means there is a minimal effusion in that area. So first you empty that fluid by swapping it out, and when you can see the small dimple there, then you push on this side, and if there is a minimal effusion present in the knee, you will see this dimple filling up again with the water. That will show that there is some effusion present inside this knee. The special tests for the knee are for the 4 ligaments. So we'll go with start with the ACL first. So ACL, so anterior drawer test. For the anterior cruciate ligament, you flex the knee to 90, stabilize the toes by sitting just at the toes, relax the hamstring muscles, having the 2 thumbs around the tibial tuberosity and the 4 fingers behind on the proximal tibia. I pull it forward and I check if the knee is stable or unstable. That is called as the anterior drawer test. Second test for the ACL is the Lachman's test. I put one hand on the thigh, other hand on the proximal tibia, and I move it front and back to see if the knee is unstable. This knee feels pretty stable. The movement is this one. So I push it back and move this forward. So I repeat, front and back to check for integrity of the anterior cruciate ligament. For the PCL, or the posterior cruciate ligament, you bend the 2 knees to 90 degrees, put the 2 heels together, and you look at the posterior sag sign. So I'm looking at the tibial tuberosities to see if one of the tibia is sagging behind. So that is called as a posterior sag sign. I don't see any evidence of that here. Then there is a posterior drawer test. Again, I sit at the toes, grab the proximal tibia and push it backwards. Grab proximal tibia and push it backward to see if there is any posterior drawer test positive for this patient, which is negative here. Okay, having done these 2, we come to the median and lateral collateral ligament. For the MCL, which is a ligament on the medial side of the knee, I have my hand on the lateral side of thigh, one hand grabbing the ankle, and I open up like this. This is a valgus stress. I'm trying to open up the medial side, and I ask the patient if he has any pain. Any pain? No. Any problem? Okay. For the LCL, it's the opposite, lateral collateral ligament. My proximal hand is on the medial side of the thigh, and the right hand is behind the ankle, and I'm bending the knee to 30 and then opening up the lateral side. The movement here is this one, in which I'm opening up the lateral side. So medial and lateral collateral ligaments in this patient are intact. And you repeat exactly the same test on the other side as well. Okay, so that's it. Then the test for the apprehension test for the patellar dislocation. For apprehension test, you flex the knee to about 30 degrees. You stabilize the knee with the hand. It should be fully relaxed. It should not be stiff in any way. And then, looking at the face of the patient, you, with the thumb, you push the patella out. In this test, you are seeing if the patient has any apprehension when I am pushing the patella out, because in patient with the high patella or recurrent patellar dislocation, you can actually dislocate the patella fully, and a patient with apprehension will not allow you to do that. They will tell you to stop when you're pushing it out. And you do the same test onto the other side. Again, the leg should be fully relaxed, and you push the patella with your thumb out and look at the face of the patient while you're doing it. So this is a negative apprehension test for this patient. Test for the meniscus is the MRCS test, in which you fully flex the knee, bend the knee, sir, fully flex the knee. This will grind the posterior horn of the menisci. Then you internally rotate the leg like this and extend it. Then you flex again and rotate the other way and extend it gently. If the patient has pain doing this, this means his medial or the lateral meniscus is torn or caught between the condyles. Here, repeating on both sides, rotating it, extending, and you look at the face of the patient while you're doing that to make sure you're not giving him any pain. So this is the MRCS test for meniscal tear.